So I think we can start now. Good afternoon, everybody, and welcome, a warm welcome to all of you on behalf of the EANS Brain Tumor section. We welcome you to our webinar. Our topic will be the management of meningiomas, a field which has moved forward significantly in the last few years, as you all know. And in the coming 2 hours, we're going to discuss novel molecular insights, which also impact the clinical management of our patients. And to do so, we have invited 4 distinguished experts in the field who will talk about novel aspects and future perspectives. And I would also like to welcome my colleagues from the webinar team, Dr. Freischlag and also Dr. Bartek, who will join me for the discussion. And last but not least, I would like to encourage you, all our audience, to ask questions in the Q&A box, and we will hand them over to our speakers after each talk and discuss each talk separately. And for the sake of time, I would suggest that we get started. And it's my pleasure to introduce our first speaker, Professor Felix Sam from the Department of Neuropathology here in Heidelberg. He will give an overview of all the molecular aspects which have evolved during the last few years. And amongst others, Dr. Sam and colleagues have developed the meningioma methylation classifier you all may be aware of. So thank you very much for joining our neurosurgical audience today, Felix, and the stage is yours.
Yeah, thank you for the invitation and for the kind introduction. Always my pleasure to be with the neurosurgery colleagues. And indeed, I will give you an update on the classification of meningiomas and the molecular markers that now with the new WHO classification have also their role, their established role in meningioma diagnostics. So as you all know, there are 15 different subtypes of meningioma that have been there already in the previous classification. But there are some changes, and just one of the first that I want to introduce here is that what we have learned so far, that rhabdoid and papillary meningioma are grade 3, that has been abandoned. So that is already a novel change, and I will go into detail there, that seeing that meningioma have papillary or rhabdoid cells, when a neuropathologist tells you that, that does not mean anymore that these are grade 3, because we have learned that this pattern alone does not necessarily determine that the patient has an aggressive outcome. When you look in the WHO classification, which you do not need necessarily because the neuropathologists do that for you, but if you want to, it is now very well structured because all of the different chapters have these tables which very clearly summarize you the entire text and show what the essential diagnostic criteria and additional desirable diagnostic criteria are. And here, of course, the example for meningioma out of the classification. And the main pillar of diagnostics is still histopathological features. But alternatively, we now also have specific mutations or also DNA methylation profile as criteria in meningioma diagnostics. And that is also what I will show you today, why exactly and which exactly these are. And one of the first and most important changes is that now a meningioma, if it looks low grade or if it looks high grade, independent of that, if there is a third promoter mutation, which we also often find in glioblastoma, in oligodendroglioma, also in melanoma, for example, if there is a third promoter mutation, this is likely a high-grade meningioma, and therefore the WHO team has now decided that presence of third promoter mutation means grade 3 for this meningioma, irrespective of other features. And that is very nicely shown. For example, here in blue is the outcome of those cases which had a third promoter mutation in the meningioma, and you easily see that the PFS here is even worse than in the average anaplastic meningioma. So that is really a clear marker for an aggressive outcome in meningiomas. That was already known quite some years ago, but only during the past 5 years, there have been additional data that has supported this finding, confirmed it, and therefore now it could be included as a diagnostic criterion. And therefore, of course, it also needs to be tested in case there is a higher grade meningioma suspected. Second, in the same direction, there is the new marker of CDKN2AB deletion that is also known from astrocytoma, oligodendroglioma, that shows a higher grade of astrocytoma and oligodendroglioma, for example. And exactly like that, it is now also for meningioma. If there is a meningioma, no matter how it looks, if it has a CDKN2AB homozygous deletion, then it has an unfavorable outcome. Here, the yellow line, these are grade 2 meningiomas. If they have a CDKN2AB deletion, the outcome is worse than the wild type. And similarly in the grade 3, if there is no alteration, they of course already as grade 3 have a bad outcome, but if they have in addition the CDKN2AB deletion, it is even worse here. And that was also already known actually years before with other methodology, but only now there were enough data to really confirm and substantiate this association of high grade and CDKN2AB deletion, and therefore it has now been entered as a novel criterion. So if it looks grade 1 under the microscope, but has a CDKN2AB deletion, or what I have shown before, a third promoter mutation, it is a high grade 3 meningioma per definition. Then there were other possible criteria that were discussed in the WHO team, but not introduced into the novel classification because the data was not mature enough or not enough data. And one of them is the loss of the trimethylation of 8,3K27. That is something that is already useful in, for example, neurofibroma, MPNST, ependymoma, and we also tested that in meningioma and found that cases that have a loss of this marker, so if only the vessels are positive and the rest of the tumor cells are negative, they have a worse outcome, that is the red line here, than those which are positive for this staining. We see that for all meningioma. We also see that if we just look at grade 1, grade 2, at these borderline cases. And meanwhile, but that was too late for the classification decision, there are additional data from Tübingen and from Toronto which have confirmed that this trimethylation loss is an indicator of worse outcome. But as said, the classification was already written when that was published, so we could not include it yet, but probably then in a subsequent version of the WHO. Similarly, there are novel markers which are also associated with high-grade meningiomas, and these are mutations in BAP1, which was found in Boston first, and PBIM1, which was also found in Boston, but by Tarek Yuratli, who is now in Dresden again. And they found that, for example, this BAP1 deletion or mutation is associated with worse outcome. And interestingly, these cases often have then rhabdoid or papillary morphology, and we're not yet there, but we may in the end find that those BAP1 or BPRM1 mutant cases are those which are truly the rhabdoid subtype or truly the papillary subtype, and are then also really associated with high-grade outcome, while, as I have shown you before, so far papillary and rhabdoid histology alone are not yet criteria anymore for a high-grade assignment of the cases. But then there is even more molecular data, and that especially in the last 2 or 3 years. And I start here with the study from Toronto, from Gilary Sadeh's group, who has investigated methylation, RNA sequencing, and copy number alterations in meningioma, and found 4 subtypes with different outcome here. One of them which is more immune enriched, one of them which is more proliferative, one of them which is more metabolically active, and one of them who has as a specific feature no NF2 alterations. And so they propose here this 4-tiered scheme of meningioma subclassification based on integrated analysis of distinct methylation, RNA expression, and copy number findings in this study. And similarly to that, a study from UCSF from San Francisco, led by David Raleigh in the radio-oncology department over there, they have suggested 3 different subtypes. One of them is also defined by no NF2 alterations, so-called Merlin intact. One of them who is like that in Toronto, defined by high immune enrichment, and one of them which is defined by high proliferative activity or hypermitotic activity, which is in the end the same, also similar to the Toronto group. And finally, also here already in 2016 in Heidelberg, we have proposed subtypes based on methylation profiling, which we called 3 of them benign, as they have, as you see here, rather favorable outcome, 2 intermediate groups with, as the name already implies, intermediate outcome, and 1 malignant group, similarly to the others thereafter, also defined by DNA methylation profiling. And there were several studies that also, in addition to those which I have already shown, confirmed the role of DNA methylation profiling to identify clinically relevant subtypes of meningioma. Currently, as you see, we are working on a consensus to identify if these 3 subgroups from UCSF, the 4 subgroups from Toronto, or the 6 subgroups from Heidelberg are the most appropriate to replicate the individual outcome for the patient and to have the prognostication there most accurately. And that is something that currently the C-Impact Consortium, a group of neuropathologists, neurosurgeons, and other associated fields, is working on to find an international consensus there. On top of this methylation profiling, we had performed here, starting from Heidelberg, but with international collaborators, a prospective study to validate the value of molecular grading in meningioma. And we have included more than 3,000 cases there, or actually more than 3,000 samples. And these were derived from 2,868 individual patients. And of about 1,000 of them, we had specific molecular and also clinical outcome data that formed retrospective and also prospective cohorts over the course of 5 years. So there we could really, in a real world all-comer setting, identify if this molecular grading that goes beyond TERT and CDKN2A, but also includes methylation and copy number profiling, makes a difference in the prognosis and prognostication for the individual patients. And we then found out that actually the best approach is to merge, as often, to merge all the different learnings that we have over the centuries and the past decade. So the histology-based WHO grading that started already with Bailey and Cushing a century ago, the methylation families that were more recently identified, and the chromosomal alterations that already were identified in the 60s and 70s in meningioma by Zhang, for example, and others subsequently, that we merge all of this information and build a score that assigns numbers to low morphological grading, high morphological grading, to low molecular grading by methylation, high molecular grading, and to few or many copy number alterations. And then we sum that up to a score that gives you a low and intermediate or a high likelihood of recurrence. And if you use that here in the integrated model, we have a very nice separation of 3 different outcome groups, which is statistically superior to the single grading and also to the WHO grading, which we know today. And that is especially interesting for those cases which are, from a diagnostic perspective and for decision-making perspective, often most challenging. And these are the cases where you not really know if they are grade 1 or already grade 2. So here in black, we see the average grade 1, and in yellow, we see the average grade 2 cases in our cohort. The dotted yellow line shows those which are by so far standard of art grade 2, but by our novel approach have a low risk profile. And you see they even are better than the average grade 1. And as you can easily imagine now, the black dotted line are those cases which look like grade 1 and by state of the art would get a WHO grade 1 diagnosis, but by our integrated approach have a higher risk of recurrence indication, and indeed they are similar to the average grade 2 cases here. And based on that, we devised a diagnostic algorithm which makes it a little bit more easy for the respective neuropathology department to identify in which cases this additional analysis are actually needed, because otherwise running that in every sample would probably be a little bit expensive over time. So we have identified that some subtypes that histologists will easily identify do not need further workup because they are obviously low or intermediate risk, and only those which do not belong to any of these morphological groups, they benefit from this more extensive analysis. And depending on what you have on site in resources and infrastructure, you can use methylation array to get the full scope of information, methylation score, copy number, and so on. You can also identify single alterations if you have only or you prefer FISH analysis or single copy number analysis. And if you have rather single gene analysis at hand at your center, you can also start with this and check, for example, for TERT alteration and so on. And then you can go through this diagnostic algorithm to end up with a much more improved precision of prognostication for the individual meningioma patient. And when we look at this over the entire cohort here represented by 100 representative patients, we see that in WHO grade 1 cases, so all of those which had grade 1 diagnosis based on the state-of-the-art histology so far, we find about 1/3 of those which actually have a grade 2 outcome and which we would identify to have a grade 2 outcome applying this novel method, but would not have found them with the current state of the art before. Similarly, in grade 2, you identify about a fourth that had a better outcome, but also about a fourth that had a worse outcome than the state of the art technology would imply. And even in grade 3 cases, you find some of them which have a low risk if you apply this additional technology that I just introduced here and calculate this integrated score that was devised in this study. As already said, that necessarily comes with some additional molecular workup, is costly, also needs a lot of infrastructure that you have on site in your neuropathology department there. And therefore, we also devised a technology that makes it cheaper, easier, and faster, and that is based on nanopore sequencing, and that I will briefly introduce at the end of my talk here. We have developed a technology that based on a very small nanopore device that you can see here, so it's not much larger than a cell phone. You can actually enter the native DNA there, and during sequencing, it will identify if the DNA fragment that is just in there is of interest for your diagnosis or not. And if it is not of interest, it just ejects it again. And therefore, you do not need any preparation to enrich for DNA fragments of interest in your analysis, but just on the go in the native DNA, you enrich for what is important to identify a high or low-grade meningioma, but also working on glioma, for example. And that is something which makes that much faster, much less costly. This device costs like $5,000 or euros in comparison to 250K of the typical devices used before. And that gives you the entire information, now in this example here of a glioma, third promoter mutation, copy number, methylation score. And we are using that already here prospectively for frozen sections to make diagnosis much more accessible and much more faster for the cases that are taken care of here in Heidelberg. With that, I'm already at the end. I thank everyone involved in those studies, which I showed you from our group, but there are also, as mentioned, many from the other groups like Toronto, UCSF, Düsseldorf, and so on. And I'm looking forward to your questions to this presentation. Thank you.
So Felix, thank you very much for this very comprehensive overview. I think you put a very complex topic in a very comprehensive presentation, and also good for neurosurgical applications. I can't see any questions in the Q&A section. Are there any questions from the panelists?
Yeah.
Professor Jenkinson.
Thanks. Felix, that was a fantastic talk. I just wondered what you think about integrating your model, your calculator with additional clinical data, such as we're going to hear about the role of extensive resection, skull base versus non-skull base location, for example, and other patient factors such as comorbidities. I would just wonder your thoughts on that.
Yeah, that's an excellent point. And you probably remember that Farshad Nasiri from Gilare's group once published a nomogram for meningioma patients, which actually implemented also the information on extent of resection, age, and also biological sex, which is very important in meningioma prognosis. That is something we have not worked on yet here, because we found that the very obvious factors like cross-total resection or not make, of course, a difference, but all the other more subtle differences did not make a significant effect in the cohort that we had here. However, the clinical documentation of these cases was also not always at that detail that we could really incorporate this information for the entire cohort. So the, complex answer or short answer, but based on a very complex data set, is we don't know yet, because not all of the annotation was available, but certainly it would make it much better if this annotation was present and we could include it in these models. So Christine, you are mute.
You're right, thank you. There's one question in the Q&A section. Juan Montero Silva asks, what are the practical clinical implications of this new developments? Can you comment on that?
Yeah, so we see that more or less on a daily basis, and therefore that is a very important question, that we have cases, for example, of a young patient where it may look like a grade 1 meningioma, but you ask, why is that happening already in a young patient? Or on the other hand, a patient that has really marginally enough mitotic counts to call it grade 2, but everyone else in the clinic says, okay, but that is a not really bad looking meningioma. Is it really grade 2? And then the tumor boards or also referral cases are coming in where we are asked, okay, do you have additional information based on these molecular markers, if that is more likely to be low grade or more likely to be high grade, or even, but that is rare, unfortunately, may there be any targets for treatment even. And therefore, we have these cases indeed on a daily basis. We have, as it is in WHO classification, also the mandate to test for CDKN2A and TERT, because that is now part of the guideline. And therefore, this has really routine diagnostic setting, meanwhile, at least for TERT and CDKN2A, and for select cases, also for these additional technologies.
Okay, I think that was a very, good answer to this question. I think there's one more question coming in. Why were CNA and DNA methylation only chosen to inform the predictive algorithm when RNA and protein level data was helpful in classification?
That was used in one of the studies. There is also an excellent comment. So in one of the studies, protein data was also present and RNA data. And we found that from a practical perspective, and actually also the study which evaluated proteome and RNA, they also found that from a practical perspective, dealing with formalin fixed tissues and so on, it is more pragmatic to only look for methylation and mutations, and that is mostly already established in the neuropathology department. So we are currently seeing an increase in proteomics facilities and so on, but it's not yet there everywhere on the one hand. On the other hand, the RNA is often much degraded in the paraffin tissues and therefore may not be that reliable. But we are also seeing that now technologies investigating RNA on a FFPE basis are also getting better results. So sooner or later, this will maybe be part of this analysis, but it would, of course, also add an additional layer of analytical cost. So therefore, most of these models are currently sticking with DNA or methylation-based analysis.
Okay. And maybe one more question from my side, Felix. Can you just briefly comment on the location-dependent mutations which were discovered in meningiomas and the therapeutic consequences or implications?
Yeah, good question. So all of the studies that I have shown have confirmed what Priscilla Prastianos and also Murat Günel's group had already found quite some years ago, that the skull-based meningiomas are enriched for the AKT1, smoothen PIK3CA mutations. And these are otherwise rare, which are then mostly NF2 mutant. They also form, in all of these models, they form distinct subtypes, which are then not NF2 mutant and have these other mutations. And therefore, if they are smoothened or AKT mutant, of course, also are amenable to targeted therapy. They are often grade 1 histologically, but at a, you know better than me as neurosurgeons, at a location that is more difficult on the skull base. And therefore, in these cases, it really is worthwhile to test for the mutations in case that resection alone or radiation does not work. And I know only of few cases, but in those that has worked well with AKT inhibitors. And we are, I think, also all looking forward to more mature data of the studies that are using SmoothNet and AKT inhibitors, for example, also from Priscilla.
Right. So thank you very much again, Felix, for this very nice, informative talk. And I think for the sake of time, we have to move on to our next speaker. Thanks again. Our next speaker will be Professor Matthias Simon. He's the chair of the Department of Neurosurgery in Bielefeld here in Germany. And he is also the chair of our neuro-oncology section in the Eans at the moment. And Dr. Simon will address the impact of the extended resection, and also in light of tumor location and all the novel molecular findings Felix just addressed. So Matthias, are you there?
Yes, I am, and I hope you can all hear me well. I'm trying again to share my screen.
So welcome again and looking forward to your talk.
Okay. Can you see it?
Yes, we see it.
Okay, very good. Well, thanks, Christine, for the nice and kind introduction. What I will talk about is actually the role of the extent of resection, and I will not talk a lot, only show one slide on meningioma genetics. Well, the role of the extent of resection, this is a core issue when dealing and managing meningioma patients. The next slide.
I'm sorry, Matthias, you have to switch presenter's view and presentation view again.
Yep. Is that better? Sorry about that. So my first slide actually shows what I would like to call the problem. In the upper panel on the left side, you have the patient presenting with a large left occipital meningioma that involves the convexity tumor, the dura, the falcotentorial dura. And that was believed to be taken out completely, but on the 3-month scan, you can see something that was likely left over. And that turns out in about a year or so to become a very formidable tumor recurrence. So residual tumor can regrow and can cause recurrences. This is the problem. And you can also look at that in a more scientific way. And in the lower panel, what I'm showing you is taken from a publication from Gillespie et al., which is actually from Michael Jenkinson's group. Sorry if I'm spoiling anything of your presentation, but I like the paper. What that panel actually shows you is that residual tumors grow, and they grow at a varying degree, quite different degrees. So this is the problem. So if residual tumor matters, if extent of resection matters, we have to find a way how to assess extent of resection. The traditional way to do this is to follow Donald Simpson and the so-called Simpson grading. His seminal publication was published already in 1957, so that's 66 years ago. The classification scheme is still in use by many, if not most of us, though it has come under a lot of criticism in more recent years. Briefly, a grade 1 resection means that the tumor and also the dural attachment is completely resected. If you leave the dura behind but coagulate it, you have a grade 2 resection. A grade 3 resection means removal of the bulk of the tumor, but tumor infiltrated the tumor is left untreated and left behind. Grade 4 refers to a microscopically incomplete resection, and grade 5 is a simple decompression and operation that, if at all, we rarely do today. Now, what is special about this classification, and why didn't he just distinguish between, let's say, a complete and an incomplete resection? Well, because a meningioma is just not a bulk, a mass that compresses the brain, it is also a dural disease. The Simpson grading is a lot about how to deal with the dura. And the biological basis behind it is shown on the next slide, which is a very old one, but still this is a very good publication. Quite a while ago, investigators found that surrounding the tumor, there are tumor islets, there's tumor infiltration in the dura. So meningioma is also a dural disease. The next slide shows you what we know about the relation between extent of resection and prognosis when using the Simpson grade. I'm showing some data from my own group here, and what you can see and what you will find throughout in the literature is that yes, the degree of resection measured by the Simpson grading matters. Simpson grade 1 is better than 2, than 3, and grade 4. Yes, there is a difference between grades 1 and 2, and yes, it is also true that this difference is rather small in benign tumors. But if the sample size is large enough, you will find a statistically significant difference. Now, many other authors have also published on this issue, and I will not show you all the various publications, apologies to all the authors, but rather a review that was recently published. The panel is, the figure is taken from this review, and what you can see and what I'm showing on the slide is recurrence rates versus degree of resection using the Simpson grade. I found it somewhat puzzling that the authors of this review concluded that the Simpson grade is no longer relevant. I would disagree. Look at that. All these publications, all in this review, all publications with the exception of 2, show that there is a correlation between extent of resection in terms of Simpson grade 1 versus 2 and 3 and recurrence rate. at least in my opinion, the Simpson rate is still relevant. But this review also points out that the Simpson rating has some very severe flaws, like it is an intraoperative subjective assessment. Maybe imaging can do better. And there's also the issue, like in the glioma world, that residual tumor volume rather than extent of resection might be the parameter that should be used for risk assessment. And we've already heard about the molecular biology and the advances in this field in the meningioma world. And of course, when talking about extent of resection, we have to place that in the larger field of risk assessment with respect to recurrence. Let me just show you a few more slides and go into a little bit more detail. Imaging. Imaging is probably better than we as surgeons are when assessing residual tumors. In the upper part of the slide, you can see a series from Überscher et al. They investigated 52 prospective cases and found that among 37 cases with a Simpson rate 1 or 2 resection, an astonishingly high 40.5% had residual tumor when these patients underwent MR and somatostatin PET scanning. And indeed, quite a significant fraction of these patients was identified by the PET scan. So maybe imaging is better than the surgical impression. Data like the data I'm showing you here has recently prompted Haslund-Winding et al. To propose something that is called the Copenhagen grading. The idea behind that is to describe extent of resection in a not so subjective, in a rather objective way. They use histological assessments of the margins of resections and then imaging, a 3-month MRI, and again a somatostatin receptor PET. And then there's a score, and at this point, they're trying to find out if based on this score, follow-up scans for patients patients can be spared follow-up scans which are not necessary because the risk of recurrence is low. It will be very interesting to see how this grading scheme will work in clinical reality. Another issue is tumor volume. I'm showing you just one work because it was a very large series, almost 1,000 patients, most of them WO grade 1. On the left side of the upper panel, you can see that recurrence-free survival varies with the Simpson rate, as I have shown you. And yes, again, it makes a difference if you have a grade 1 versus 2, 3, or 4 resection. Now, on the right side in the upper panel, you can see that residual tumor volume also matters. Let me put some figures on that. The hazard ratio for Simpson grade 1 versus 2 resection in terms of progression-free survival was 1.7. To have a similar hazard ratio when talking about residual tumor volume, you are talking about a tumor volume of approximately 10 centimeters, 10 cc. It's quite a number, and that may suggest that volumetry may not necessarily be able to replace things like the Simpson grading, maybe because it does not assess dural involvement. Nevertheless, at least in this series, when doing a multivariate analysis, the Simpson grading was no longer significant, but rather residual tumor volumetry. Will be interesting to see how this concept goes. When looking from the glioma perspective, there's a similar discussion: is extent of resection or residual tumor more important? Most people, in the end, in clinical practice, use extent of resection because you can have an easier semi-quantitative scale. Let's see if something like that evolves in the meningioma world as well. Then there's one point that I think is sometimes, somewhat overlooked. I think one of the real flaws of the Simpson grading is that it is somehow differently applied in different tumor locations. The achievable Simpson grade in the resection varies a lot with tumor locations. It is actually quite difficult to not have a grade 1, a Simpson grade 1 resection in a true convexity tumor. However, in the skull base, it's very different. And then in this work, the authors found there even was a differential prognostic impact of the Simpson grade depending on tumor location. Well, is this really biology, or may that not rather point to a varying reliability of the intraoperative assessment of extent of resection in different locations? Maybe one of the conclusions should be that we need resection, degree of resection grading schemes that differ with tumor location-specific schemes. And then any debate on the extent of resection has also taken into account that resecting a tumor is not all that you can do. There are non-surgical alternatives like radiosurgery or radiotherapy. Can radiosurgery and radiotherapy act as substitutes for aggressive surgery? The answer is likely to some extent. I've given a few references where the authors more or less come to the same conclusion, but there are even some data out there where the authors fail to show that radiosurgery or radiotherapy is a significant predictor of recurrence-free survival. The panel on the slide, I think, is quite illustrative. This is from the paper by Brzymielowski et al. You can see a lot of curves, most delineated recurrence-free survival following Simpson grade 1, 2, and 3 resections. Please look at the panels C and D. Here you can see the Simpson grade 4 resections, the resection with macroscopic visual tumor. And yes, of course, if you do radiation therapy or radiosurgery to these cases, recurrence-free survival improves. That's the difference between the panels D and C. However, you do not quite reach, the degree of recurrence-free survival that you have in a Simpson grade 1 resection. It's more like a Simpson 3 or maybe 2 resection. This is essentially why I have written on the slide, radiosurgery and radiotherapy can act as a substitute for aggressive surgery to some extent. And then, of course, there's the issue that not all tumors grow, some don't. And wait and scan, I think, is something that we do all the time, and probably more frequently than we often believed. It's quite interesting, if you look at that into this topic in more detail, that this is often based on, well, somewhat limited data. I'm showing you here work from a Korean group. These people, these authors investigated 221 patients and followed them. And as you expect, some tumors grow, some don't. But I think that is not the most important message from this plot. What that plot actually shows is that the number of tumors followed for many, many years is very small. So I would think that our wait and scan decisions are often based on very limited follow-up data. We don't really know what happens 20 years after the initial diagnosis of a meningioma. Such data can also be used to delineate predictors of tumor recurrence, but these predictors may also not work quite as well as one thinks. This is a patient that we treated a while ago, incidental convexity meningioma, that was diagnosed during the treatment of a chronic subdural hematoma in the contralateral hemisphere. If we apply the score that the Korean colleagues proposed, the tumor is 22 millimeters, a little smaller than the 2.5 centimeters that some think should be a threshold for active versus non-active for treatment for observation. There's no calcification, there's no edema. The tumor is hyperintense in the T2 flare-weighted images. If we use the score described on the previous slide, the score is 4, and the patient should have an intermediate risk for progression and should, well, at least consider surgical treatment. I wonder if this is a way that we all would choose for this guy. I tend to think that location is important, what risks are involved if the tumor grows on this specific location. In this case, the vicinity to the sinus, it's a settled sinus, which may limit aggressive surgery at some point, maybe a concentration. And then again, follow-up, long-term follow-up needs compliance. Am I sure that this patient will be compliant? And then finally, surgical risks, of course, increase with age. And then when we talk about extent of resection, we of course have to account for the biology of the tumors. or if you want, the WHO grade, the malignancy. On this slide, I'm showing you degree of resection measured by the Simpson grade for atypical meningiomas. Two series on the left. This is data from my own group. On the right, a more recent publication, a smaller series, but this author also did volumetry and provide volumetric findings. Now, the message here is that I'm showing you Simpson grades, and the Simpson grade matters. There's a large difference between Simpson grade 1 and 2. This is, I would think, biological fact that is often overlooked, because in most publications on non-benign meningiomas, the authors usually distinguish only between gross total and subtotal resection. But you know, that is a statistical artifact because the series are usually rather small. Another important point is what to do with the brain invasive but otherwise benign meningiomas. A group of tumors that, from a histological point of view, are somewhere in between, and there's a lot of discussion in the last year what to do about brain invasion. Goes back into the last century, in the last actually. We've recently reviewed, performed a systematic review of these tumors. The data out there is fairly inconclusive. We don't know if such tumors are, you know, more like a typical or more like benign meningiomas. I like to err on the safe, or well, I like to be or err on the safe side, and I'm treating these tumors as if they were atypical. Now, molecular data and molecular progress has already been mentioned. And actually, what I want to say with this slide has already been part of the discussion. And this was Michael Jenkinson's question: what are the clinical correlates? I mean, there's an amazing progress when it comes to the delineation of molecular genetic and molecular biological findings in these tumors, but we also need to have clinical correlates to come up with clinical useful classifications. For example, in the fine paper by Marth et al., which has already been described, when you read through the paper, there were 514 patients, very good, but no location data. And if I'm not mistaken, almost half of the patients were of WHO grade 2 or 3. So at least in this series, there's probably some bias in the clinical series. I think we are all very excited that the Heidelberg group and others are now collecting more patients, are collecting prospectively patients to provide the best clinical data that we need to have in order to use all the molecular data. Just one more slide on molecular and, well, cellular biology data. I've been involved in a little bit of immunology research, and I don't want to go into too much details, but basically, yes, there's an immune reaction to a meningioma, and the more reaction, the better the progression-free survival. I'm showing you this slide because from other diseases, we know that immunotherapy works best if there are only small tumor loads. So maybe if we think into the future, and if we envision new treatments for meningiomas, for example, immunotherapy treatments, well, then extent of resection has to be assessed and analyzed also in view of these new treatment modalities. Back to basics, I've already talked about tumor location. Tumor location is important, and the degree of resection, the Simpson grade that you can achieve, is not something that you can choose freely. It is often dictated by tumor location. For example, it is relatively easy to do a Simpson grade 1 resection in a convexity tumor, even in a Feld-sign meningioma, and therefore I think we probably all would do that. And there are also some small skull-based meningiomas with a small dural attachment where a Simpson grade 1 resection should be or is possible, and yes, in these cases I would go for that. Same is true with ventricular meningiomas. But look at these tumors that involve the sinuses and involve the falcotentorial junction, or meningiomas in the pineal region. Tumors like these ones, you can't take them out completely like a Simpson grade 1 resection. Maybe in some cases a grade 2 resection is possibly more likely a type 3 resection, Well, if you think about the case with the falcotentorial involvement or in the pineal region, if you find adherent veins, you should probably even go for grade 4 resections. Yes, you can probably take the anterior third of the sagittal sinus. You can take the non-dominant transverse and sigmoid sinus. You have to pay attention to collateralization. I often try to carefully take resect the outer dural layer of the sinus. You can, as shown on my slide, you can resect the sinus edge and suture it. That works well. You can extract tumor fragments. I would be cautious to do more aggressive resections have been associated with a relatively high risk for permanent deficits and mortalities. I've given 2 references, very honest papers, read them, and then I think you will agree that when it comes to the sinus, caution is often the way to go. Even though we will hear from Michael Bruneau about skull-based meningiomas, it's just to make my point here that location matters. I'm showing you some skull-based examples, tumors involving the sphenoid wing or the posterior fossa involving the petrous bone and the clivus. These are cases in which, if you're really lucky, you can get a grade 3 resection, but anything more is usually very difficult to achieve, if at all. And also, one spine slide should be allowed. Meningiomas also occur in the spine. You can see, in the upper panel, a case that recently operated. I think the data out there are quite clear what you should do. You should not go for a Simpson grade 1 resection. Simpson grade 2 is probably fine. I've shown you figures from a recent publication. Only a third of the cases had a Simpson grade 1 resection, very low recurrence rates. And there is a recent review of some 900 patients out there that clearly shows that going from a grade 2 to a grade 1 resection increases your rate of neurodeficits, but it does not improve progression-free survival. What I like to do is something I like to call a Simpson grade 1.5 resection. I like to take out the tumor and then something like the inner dural layer, which is often possible, and very often you find a cleavage plane and you coagulate. I'd like to end here and summarize. I think extent of resection matters. It matters most in patients with non-benign meningiomas. And I've talked so much about dealing with the dura, and that in most years there is a difference between grade 1 and grade 2 resections. Therefore, I think that the Simpson grading is still relevant today. However, there are significant flaws. I'm looking forward to better definitions of extent of resection by imaging techniques. Maybe indeed somatostatin receptor PET will help. And I've pointed to the issue of location, and something that we should really do is to develop resection grading schemes for different locations. And finally, any discussion of the extent of resection has also to be placed in a larger context. Extent of resection is not the same as progression-free survival. Yes, of course, there's a place for wait and scan if you want for a Simpson grade 4 operation. And we already heard about the great advances in molecular biology and genetics, which are very exciting. Thank you very much for your attention. I'm, of course, happy to take any questions that you may have.
Matthias, thank you very much for this very nice overview on the extent of resection from different angles, which matter from a clinical perspective. There was already one suggestion from the Q&A box. I think it's a good suggestion, and we should pick it up and work on it. Why do the neuro-oncology and skull-based sections don't join together to build an MRI-based post-op scale that can mimic the Simpson grading scale? I think that's a good idea, and we could address that together. Thank you very much. So, but there's also one question to you from the audience. Somebody's asking if the immune response could be associated with peritumoral edema, and what do you think are the implications of this?
I probably shouldn't have shown the slide. Difficult to say. This is really initial experimental work, and really the only reason why I've shown this slide is to make the point that extent of resection is not something that you have to discuss in isolation. You have to discuss it against the background of other treatments. And if at some point things like immunotherapy will work, we may have to discuss this issue in another way. What I cannot answer your question right away, but what we can take it down and can answer later after looking up some things.
That would be good. And I think it's not the focus of this talk, actually. So are there any questions from the panelists?
Yes, Matthias, thank you for your very nice talk. The Simpson grading has one, in my opinion, one major flaw. It's always based on the decision or on the ideas of a surgeon. How do you deal with that in your department? Where do you note Simpson grading? How do you use that in your everyday practice? Or do you use it anyway?
I would think we use it, well, we use it in our department and we are aware of the flaws. Again, I think the Simpson grading is something that works well in the convexity for falcine tumors. It is more difficult to use in skull-based tumors. Maybe in such cases, one should resort to distinguishing between gross total and subtotal resections. Also, what we do, we want everybody to have a 3-month scan, and then based on if there's a residual tumor and most importantly histology findings, we have them undergo further follow-up scans. And so the question is, what are the clinical implications? If we just decide on follow-ups, it's relatively easy and you don't have to think too much about the grading, the Simpson grading or the extent of resection grading. And for a decision, and we recommend radiotherapy for something that's growing is not resectable, or if you have an atypical tumor and a tumor remnant that you can see on the image. So in those cases, it may not be the most important question to distinguish between if the surgeon feels it was a grade 2 or 3 resection. The 3-month scans will show.
Okay, so Matthias, thank you very much again. I think for the sake of time, unfortunately, we have to move forward. I think we could discuss this endlessly, but we have to move forward. Thanks again. And our next speaker will be Professor Michel Bruno. He's the chief of the Department of Neurosurgery in Brussels, in Belgium, and he's a well-known expert in skull-based surgery and also the chairman of the skull-based section of the EANS at the moment. And obviously, Professor Bruno will focus on skull-based meningiomas, and I think he will particularly focus on balancing the extent of resection against functional preservation. So thank you very much for joining our neuro-oncology section today, and we're looking forward to your talk now.
Thank you so much for your kind invitation. During my talk, I will try to answer the question you asked me. Do you see my slides? Because I don't see my slides myself.
Not yet.
It said you started the screen sharing.
Okay. No, it doesn't work. Just 2 seconds, excuse me. It was working when we tested. What happens is surprising. I will have to restart my PowerPoint, sorry, just 2 seconds.
Anna, can you maybe help out? Probably not.
I stopped my PowerPoint now. Okay, and I will share my screen in a few seconds. Does it work now?
It's perfect. Yes.
Okay, great. So I was saying thank you for the kind invitation. I will focus my talk now on skull-based meningioma more specifically. I will try to answer the question you gave me. And now I cannot move. So the first question, what is the difference between skull-based meningiomas and non-skull-based meningiomas? In fact, in most reports in the literature, there was a slight number of patients with more non-skull-based meningioma than skull-based meningiomas. And if we look to the large series of mailing, about more than 1,100 patients, the number of non-skull-based meningioma is slightly higher, meaning 51% in comparison to 99%, 49, sorry. Conversely, in the literature, there are some studies with more skull-based meningioma patients, but maybe it's a bias of specialization in some center, and also the difference in the definition of skull-based meningioma. So what is also the difference between skull-based meningioma and non-skull-based meningioma in terms of age and gender of the patient? In fact, in many skull-based meningioma series, they have a lower median age than in non-skull-based meningioma cohorts. And you will find also more meningiomas in the elderly population who are non-skull-based meningioma. In other words, younger patients have more skull-based meningioma, maybe in relation with the fact that the nerves are more quickly compressed and the patient are more quickly symptomatic. As usually, meningiomas occur more commonly in female than in male, and in skull-based meningiomas, there is a higher female to male ratio than in non-skull-based meningioma. It is reported in many studies. Regarding the WHO grades, there is a difference between skull-based and non-skull-based meningiomas. With higher grade meningiomas, meaning WHO 2 and 3, which are more frequent in non-skull-based meningioma, especially at the convexity location. Non-skull-based meningioma location is in fact an independent risk factor and also in relation with a high MIB1 staining index, which is a common feature for higher grade meningiomas. As I said just before, skull-based meningiomas are more likely associated with preoperative focal neurological deficit and are observed more commonly in younger patients. On the other hand, non-skull-based meningiomas are more often present in elderly patients and present and if as symptomatology preoperative seizure more commonly. Matthias has shown very interestingly the interest of the Simpson grade, which is well known by everybody. Grade 1 is macroscopic complete removal. Grade 2 is complete removal with dural coagulation. Grade 3 is with complete resection and dura not coagulated. Grade 4 is partial removal, and grade 5 is simple decompression. This Simpson grade is also very important in any skull-based meningiomas. And as it is expected in skull-based meningioma, the rate of Simpson 1 is much lower than in convexity or parasagittal meningiomas. I will not go into the detail, but of course, Simpson grade 1 meningioma has a better prognosis than any other resection grade. What is interesting in these studies published recently is that, in fact, the prognosis of patients with the Simpson grade 4 meningiomas with adjuvant radiosurgery is the same than a Simpson grade 2 or 3, meaning that sometimes the extent of resection has not to be pushed too much and that the quality of life of the patient has to be preserved and maybe the surgical treatment followed by a radiation therapy treatment. Regarding the survival, the literature showed that regarding the retreatment rate, it's not easily it's difficult to say if there is a difference between skull-based meningioma or non-skull-based meningiomas. But regarding the overall survivors, in fact, when we see very large studies, there is no difference in the prognosis comparing non-skull-based meningiomas and skull-based meningiomas. You asked me also another question. How much skull-based do we need in meningioma care? My answer will be very simple. As often as requested. What does it mean, in fact, practicing skull-based meningioma surgery? First, it is brain preservation, of course. This is the basic principle. But what does it mean in skull-based surgery? It means bone drilling. Bone drilling is a very important concept because it will allow to spare the very important structures. This is, by example, a classical terminal approach to which a skull-based meningioma, but what is important is that you extend the approach by drilling the bone. This is the lesser sphenoid ring that can be resected, that can be drilled, and you will see how it extends the approach in order to decrease the brain retraction. You see by the end how much you gain in space in order to reach the cranial base. This is, by example, one case of clinoidal meningioma. You see at the end how the brain remains relaxed after complete resection without any brain damage because the approach is tailored to treat this lesion. The bone flap has not to be big. A big bone flap is useless, but on the other hand, the bone flap has to be perfectly well placed in order to give you the best approach in order to lower the retraction of the brain. A retractor-less surgery or a surgery with a limited retraction is mainly the main concern in skull-based meningioma surgery. This is a planum sphenoidal meningioma approaches through an anterior interhemispheric approach. You can see the important concept of limiting the brain retraction. If you approach this meningioma through the right side, you have just to retract what is in green. While if you approach on the other side, the red zone show you what has to be mobilized as parenchyma, and this is the wrong way to approach this patient. The best way will be through the right side. But this image is also not perfect. This image is just this yellow line, but in fact the surgical approach is this dotted yellow line. So it means that the approach can be very minimalistic. This is a 15 millimeters approach to the skull-based meningioma with the principle of making the bulking of the tumor before making a peripheral dissection, and it allows you to decompress all important structure. Here the left cranial nerve, you have the vessels, the anterior cerebral artery posteriorly, the other optic nerve on the right side. You see with the very limited retraction. You see the bone flap, you see the postoperative imaging showing no brain lesions, which is a crucial concept when you are making skull-based surgery. The vessel control is also one important concept in skull-based surgery. In this sample, the main problem was the ACA, who was completely inside the meningioma. And in order to treat this patient efficiently, you need to have a proximal and a distal control of the vessel. The anterior cerebral artery is here. You have seen this left optic nerve. You see the dissection of the vessel. You see the debulking with the CUSA, the right optic nerve, which comes into view. And you see the complete vessel control. You will see the third cranial nerve. The retractor is on the forks, not on the brain. That is another important concept. Then you have to respect the microvessel. The right optic nerve is immobilized in order to limit the manipulation. And then through this view, you have access to the optic canal. Through this approach, you have a perfect vision of all very important structure, and you get a proximal and a distal control, which is a very important concept. Nerve function, of course, has to be preserved. As much as possible, you have also to get a proximal and a distal control. Devascularization is a very important issue in any skull-based procedure. Try to have a nearly and fast control of the vessel, feeding the tumor to perform a direct devascularization of the tumor and fast debulking. And another advice is to perform the dissection of the sensitive structure at the end of the procedure when there is no mass effect anymore, preventing any injury to those structures. Skull-based surgery means also to plan the surgery, and planning the surgery means also to plan the reconstruction in order to decrease the morbidity by sample by CSF leakage. This is an important concept in any skull-based surgery, to plan the reconstruction since the incision. You have also, as we discussed before, to know when to stop. The quality of life is truly crucial, and it is maybe better to limit the resection and to go for a further radiotherapy than to extend the resection and that the patient has a postoperative deficit after the surgery. You see, in this case, the tumor was infiltrating the superior orbital fissure, was close to the perforating vessel at the level of the carotid. It was better to stop. Exactly the same in this petroclival meningioma. A subtotal resection is better, leaving in place a small remnant, because you see there is an edema in the brainstem, infiltration of the brainstem. And if you go more further in your surgery, you have a significant risk of injuring the patient. So the quality of life is a crucial issue when you are dealing with any skull-based surgery. You have also to improve and help your surgery with any other means, meaning navigation, QSAT, neuromonitoring. Those are important to use in skull-based surgery. As I have said before, anticipation is truly crucial. You have also to know all the nuances in the surgery. You have also to be prepared to manage the complication. What are the nuances? By example, depending on the approach that you will use, you will expose more one region than another. You have to perfectly anticipate the anatomical relation between the tumor and the vascular nervous structures. And you can see for by example anterior midline skull-based meningioma that the positioning of the patient is truly crucial, and just moving the patient's head from a few degrees can allow you to make your surgery easier or more difficult. And you have not to be dogmatic. I have shown a few cases of anterior midline skull-based meningioma treated by an anterior interhemispheric approach, but this meningioma by sample was treated by another approach, a contralateral lateral supraorbital approach. We have to know all the available approach, and this lesion is not the same as this one. This lesion extends into the optic canal and was approached by an endoscopic transsphenoidal approach with resection and opening of the optic canal in order to improve, by the decompression, the visual function in the postoperative course. As I have said, you have also to be able to manage the complications during the surgery. This is a meningioma that looks very easy, but in fact, the vessels, veins, and arteries were in close relation with this tumor. And you will see the surgery, which looks easy at the beginning, dissection of the sylvian vein, no problem at all, debulking of the tumor, avascular lesion. And then what will happen is that I have to dissect one branch, arterial branch, very adhering to the meningioma. And you see that the caliber proximal is not so limited. So the dissection has to be very careful. You see how it is adherent. And you will see at some point that a pseudoaneurysm on the artery will happen. So it's difficult to dissociate skull-based surgery, meningioma surgery from vascular neurosurgery. You see this pseudoaneurysm now. What to do with this pseudoaneurysm? Leaving it in place, reinforcing the wall. Very difficult decision. It's why you have to be able to manage the complication that could happen during the surgery. You see this vessel is very, very weak now. So the time that I will make my decision, spontaneously this vessel ruptured. This vessel was still patent. You see that on video angiography, the vessel is perfectly open and finally has to be reconstructed. A clip is placed on this sylvian branch, very important sylvian branch, and then resuturate in order to have a perfect patency of the vessel at the end. this is another thing I would like to highlight. Not possible to dissociate skull-based surgery with vascular neurosurgery. And this is at the end after the fluoroscopic control and at the end after postoperative imaging showing that there is absolutely no infarct in this territory. So the last question was regarding the complementary treatment after surgical treatment. So I take just the ANO guidelines, and maybe we have to discuss a little more after the integrated score that have been developed recently. But of course, for WHO grade 1, after a gross total resection, we have just to observe the patient. If the gross total resection is not achieved, most of the time the patient is observed, but we can also discuss radiosurgery or fractionated radiotherapy. For WHO grade 2, with a gross total resection, observation of radiotherapy can be proposed. When there is no gross total resection after grade 2, radiotherapy has to be proposed. And for WHO grade 3, radiotherapy is usually performed after the surgery, and also experimental therapy can be proposed. So I have discussed with you the specificities of skull-based meningioma. The beginning of my talk was a little disturbed. Sorry about that with the presentation of my PowerPoint, but thank you for your attention.
So, Professor Bruno, thank you very much for this very interesting and also educative talk you gave. I think it was very good for the audience. There's one question from the Q&A box, which also is part of the skull-base topic. What is your personal experience with cavernous sinus meningiomas, and do you have any? What is the best option in your opinion to handle this type of meningioma?
Yes, cavernous sinus meningioma definitely raises the question of the quality of life, and the resection has not to be extended too much to preserve the quality of life of the patient. In such cases, it is most of the time the component which is extra, which is outside the cavernous sinus, which is operated on, and the remaining is irradiated most of the time.
Mm-hmm.
The idea in such tumor is to decompress the optic nerve when there is a compression of the optic nerve in order to create a space and allow further radiotherapy.
But if the meningioma is confined to the cavernous sinus, you would prefer radiotherapy?
So surgically, I will not enter the cavernous sinus because the patient will be in a bad condition after the surgery and surely will have morbidity which is not acceptable. Mm-hmm. So pure intracavernous sinus meningioma surgery will not be favorite, at least in my hands. A few surgeons have that done, but I think it is a little outdated now with the radiosurgical treatment that we can propose, or radiotherapy, fractionated radiotherapy that we can propose now.
Mm-hmm. Also, okay.
The sparing of the vision is one of the main concerns. It's why in some cases you have just to decompress the optic nerve in order to make possible, with limited risk, further radiotherapy treatment.
Mm-hmm. So functional preservation.
Of course, it's a slow growing process. Yeah. So there is, in my opinion, no need to take any risk for such patients.
Yeah. Can you also briefly comment on the role of endoscopic skull-based surgery in terms of extent of resection, but also quality of life?
That's a good question. There are several philosophies. The endoscopic approach was very valuable or very used. I would say 10 years ago, it was rising. The number of patients operated on by sample for anterior midline skull-based meningioma was higher and higher, and some surgeons have a step backward going again more and more by transcranial approach. The main concern with endoscopic approaches is the CSF leakage rate and the morbidity. You can do fantastic things through an endoscopic endonasal approach, but at the end, if the patients stay for a long time in the hospital, do CSF leakage, meningitis, and so many complications, it's the reason why the number of patients operated on by this endoscopic endonasal approach for intradural tumor has decreased. The endoscopic approach is fantastic for extradural tumors, but for tumor extending intradurally, personally, I still advocate transcranial approaches. And by sample, in order to decrease the morbidity rate, when I operate a patient for a platinum spindle meningioma, extending through the cranial base, I will leave in place a small cuff of tumor, a dural infiltration, not to enter the sinus, not to create a CSF leakage, because it will be the difficulty for the patient in the coming months or the coming weeks. While on the other hand, if there is a very small remnant in the ethmoidal cells, you follow the patient, and there is an evolution, you can irradiate the patient with the radiosurgical treatment on a very, very small residue. Those patients are treated for very big tumors, compressing the frontal lobe or compressing the optic nerve, symptomatics as soon as you treat the patient, and the mass effect is completely released, and there is just a small base infiltration. I leave the base in place without trying to resect the dura or drilling the bone. With the current armamentarium, there are other ways to treat such patients in order to have the lower morbidity as possible.
So that's a very balanced answer. Maybe it's valuable for selected cases, but maybe the general hype is not justified like that. Okay, there's one last question. Can you comment on the role of keyhole surgery in olfactory groove meningioma? Maybe it points in the same direction.
Yes. Keyhole is very important. As I have shown, the meningiomas, the platinum spindle meningioma by sample was removed by a 15 millimeter dural incision. It's quite limited. So over the years with experience, the approach has to be tailored, and a very limited approach is possible in all the cases. But with the experience, we have perfectly to know where to place the bone flap, and it is the detail that is the most important concern in this situation. But of course, I favor minimally invasive approach and keyhole approach. Yes.
Okay. So,
but if you try directly the minimally invasive approach with a limited experience, then you could be in trouble, because it's a question of details, and you have to know such details, and you have those details with the experience. So with time, the approach is more and more restricted.
Yeah, that's true. Okay, if there are no more questions from the panelists, I can't see any more questions from the Q&A box. No? Then unfortunately we have to proceed. Thank you very much again, Professor Bruno. That was very informative. And yeah, last but definitely not the least, I would like to hand over to Professor Michael Jenkinson. He's a professor of neurosurgery from the University of Liverpool, and I think he's well known to this audience as well. He is PI of the multi-center Rome trial, and accordingly, he will give us an overview of the state of art and future perspectives in the adjuvant treatment of meningiomas. And Professor Jenkinson, please go ahead. Thanks for joining us.
Thank you very much for the kind introduction and invitation to speak at this webinar, which I found really interesting, and it's great to have updates from experts in the field. So I'm just going to cover existing clinical trials that are out there and some that are upcoming, including some radiotherapy and drug trials and a few that are in setup. So the question really is, why do we need clinical trials in meningiomas? You know, we're all surgeons. We all like to think we can take meningiomas out. We can cure people. They don't come back. But as we've seen from all the previous three speakers, there are these clinically aggressive meningiomas across all WHO grades that somehow and for some reason seem to have a recurrence rate. So this is not an entirely benign pathology. And the way to try and develop new agents and new treatments for them after our surgery is through clinical trial practice. This is just a typical example. This is what drives us as neurosurgeons, having dismal cases like this, horrible anaplastic meningiomas where you do a fantastic job surgically, and then 6 months later, the tumor's back, and there are no additional surgeries or radiotherapies or effective drug treatments. So that's what drives us, and that's why we do these trials. If you think about how trials in meningiomas are structured, they tend to be front-loaded at the beginning of the treatment pathway. So people trying to work out whether after the initial surgery, we should be using some form of radiation treatment to reduce the risk of recurrence. And then they also tend to come right at the end of the disease pathway. So for those aggressive or recurrent tumors where people have been through multiple surgeries and radiation treatments, people trying drug trials. So these are in the late disease stages. There has been an explosion of clinical trials in meningioma over the last decade, and that's really matched the increase in knowledge that we've seen from Professor Salm's talk earlier on. And you can have a look online. This is a really nice review. And this is just looking at a drug trial, so immunotherapy trial in meningioma. But you can see that these are small trials, these phase 2 trials, small number of patients, only 26 here. There's also people looking at radiotherapy trials out there as well. And this is one looking at multi-session radiosurgery. So people are looking not just at standard treatments, but looking at whether we can modify or improve on our existing treatment paradigms. So just to cover the radiotherapy trials, and most of these have been published in the literature already, so there's no new data here. But this was a nice EORTC study from Damien Weber, looking at atypical and malignant meningiomas. And this was a non-parallel, non-randomized study where they were giving upfront radiotherapy of 60 Gray and looking to see how this impacted on progression-free and overall survival. And this showed that radiotherapy, certainly up to the 3-year mark, seems to have a reasonable impact, but that there is an associated toxicity with it. Of course, this is non-randomized data, so it doesn't mean we should all be going out and giving radiotherapy to our patients. The North Americans did a similar trial in parallel, the RTOG 0539 trial, led by Leland Rogers. This is the intermediate risk group where they bunched together newly diagnosed grade 2 meningiomas and recurrent grade 1 that had subtotal resection. And again, they were giving radiotherapy in that adjuvant setting at a lower dose, and again showed similar control rates in terms of progression-free survival. Slightly lower adverse event rates, probably related to a slightly lower radiation dose. The North American group have just published their low-risk meningioma cohort. Again, this is telling us something that we probably already knew or thought we knew as surgeons, or we know from our experience of our practice, that if you have a grade 1 meningioma and you do a good resection, by and large, these tumors are fairly well behaved with good control rates. What they did report in this data is that size matters. So bigger tumors tended to have a worse progression-free survival rate, although they didn't postulate as why that might be the case. But their concluding thought was really whether there is a role for radiotherapy in subtotally resected tumors, however we wish to define that, and I'll cover that a bit later on. As already mentioned, we're running the Rome EORTC 1308 trial. This is across the UK, Europe, and Australia and New Zealand. And this is looking at newly diagnosed grade 2 meningiomas undergoing resection and randomizing them to either radiotherapy in the adjuvant setting or to active monitoring with the idea of looking at whether the radiotherapy reduces the recurrence rate from 40 down to 20%. So the trial has now completed recruitment and is in the follow-up stage. What we did for this trial, and what we tend to do for a lot of trials, is the Simpson grade gets condensed into a gross total resection rate. So we say, let's consider the solid part of the tumor as a gross total resection. So Simpson grades 1 to 3 get amalgamated here. What we see in the trial, though, is that the majority of resections are Simpson 1 and 2, as you might expect, and the majority of these tumors obviously are in the non-skull base location. Somebody asked a question in the chat about what do we do for subtotally resected grade 2 meningiomas. Certainly, in the absence of a trial to recruit patients into, we take a pragmatic approach. We send tissue off and get their recurrence risk score back from our local genomics hub in the UK, and use that to guide whether we think we should be giving upfront adjuvant radiotherapy or whether it's reasonable to offer a period of monitoring, and again integrate that with the clinical data, age of the patient, any comorbidities, likely life expectancy, for example. One thing we did get out of the Rome trial so far is that surgeons and oncologists are very bad at explaining clinical trials to patients. And so we had a whole piece of work that tried to address how we describe clinical trials and how we explain randomization and how we can possibly improve recruitment into trials in the future. The North Americans are running a very similar trial. Again, this is led by Leland Rogers. They're a few years behind us in terms of recruitment targets and results plan. But again, essentially a very similar trial. The plan, once both trials are published, is to take all the data sets and do an individual patient data analysis to create a data set that's going to have well over 300 patients that will provide more useful information than just the two smaller trials. So what about drug trials? That's radiotherapy done with. Drug trials, we're all probably aware of this one. This is a nice study from Matthias Preusser, the 1320 trial using trabectedin, based on some lab work suggesting that trabectedin may have an impact on meningioma growth. It's a drug that's already used in sarcoma management. And so they randomized 2-to-1 between trabectedin and local standard of care. And this was in people with meningiomas who the local treating teams felt had no more local therapeutic options. So no more surgery, no more radiotherapy options available. And they had to have measurable disease on the MRI scan. Sadly, as we all know, the drug didn't have a positive effect. So no difference between standard of care and giving the trabectedin. There was no difference in overall survival. Trabectedin arm had a higher adverse event rate, as you might expect, given that you're giving a drug. They did some secondary analysis and pulled out what people were using as standard of care. And there was a suggestion of a possible signal using bevacizumab. And the idea was they were going to take this drug and try and get a subsequent study up and running called the ATTRACT study. But unfortunately, this has not been possible due to a lack of funding and support from pharma to deliver this. So that's very disappointing, but that's what we have to deal with. The other useful thing that came out of this study is it's given us some good quality prospective data of what the progression-free and overall survival rate is like in patients with grade 2 and grade 3 meningiomas at the end of treatment when there's no further local treatment. And that's good for benchmarking for designing future studies as we move forward. What about precision medicine? Maybe we should move away from these sort of poisonous cytotoxics and do something a bit cleverer. Dr. Sam has already shown, and somebody else mentioned in one of their talks about these driver mutations that were discovered about 10 years ago from various labs simultaneously, it seems, in 2013. And these driver mutations, AKT1, smoothened, these tend to be located in your skull-based meningiomas. And so what Priscilla Brastianos has done on the back of studies or case reports showing that these drugs can work is set up the Alliance trial. So this is a multi-arm trial running across North America that's got multiple arms. So they're looking at these people with these progressive or recurrent meningiomas, and they are recruiting them in, they're sequencing them, and then if they identify these mutations, the idea is that they go into each of these respective arms. So the data I've got here, which is courtesy of Priscilla Brastianos, presented at the ASCO meeting in 2020, just shows the NF2 data. So this is using a FAK inhibitor, and so they screen these patients, and if they've got the NF2 mutation, then they use the FAK inhibitor. And the idea is they're looking at progression-free survival, 6 months, and then looking at secondary outcomes such as overall and median time to progression. The cohort that they looked for, so it's interesting to look how many they registered. So they screened over 300 patients and recruited just under 40. So you've got about a 10% hit rate of getting this mutation and getting patients into your trial. And it was a mixture of grade 1 and WHO grade 2 and 3 meningiomas, and that was pre-planned. They wanted a mixture of those tumors. Pleasingly, the efficacy endpoint was met for both cohorts, both the grade 1 and the grade 2 meningiomas, suggesting that the FAK inhibitor that they trialed seems to have a signal. And the idea being that they will try and develop that into a further trial. And those other additional arms that are ongoing in the study are still recruiting. I think they found that the incidence of those genetic driver mutations is lower when you're screening massive clinical populations than in their original papers, which were much more enriched for those patients. So that's drug trials. What about observational retrospective studies? Well, we often see this in our clinic, the incidental meningiomas. I'm sure our colleagues across the world see these. What do we do with these? People have head injuries or strokes and have brain scans for other reasons. How do we pick those meningiomas that will stay small or grow? And what we've done in Liverpool is we built a database of over 400 cases, and we've integrated the imaging and the clinical features of the patients, so their comorbidities and their estimated 10 years life expectancy rates, to build this prognostic model that's freely available online to use. It's not validated for clinical use, but it can be helpful to sort of give an idea of the risk of growth. And what we found is in our cohort, there were about 10% of tumors who would progress, but the remaining 90% had minimal or no change in size. So Dr. Idslim, who's running this study, is getting external validation, and we've got a series of partners across the North America and Europe that are contributing, in certain neurosurgical departments who are contributing data, and we've got just under 1,200 patients in now, and the idea is that this will close probably over the summer, and we'll get the analysis done and hopefully have some data towards the end of the year. We've got some studies in setup. In the UK, we're just about to open a trial looking at the role of seizure prophylaxis for meningiomas. Nothing that's been discussed so far in either of the two really good surgical talks that we've had, but whether to use seizure prophylaxis or not. We're just looking at whether the use of 2 weeks of levetiracetam versus a placebo reduces your risk of seizures at a year. And this is about to open. So we're going to recruit across 20 UK sites, just about 1,000 patients, and work out whether prophylaxis does work or it doesn't work. This trial is unfortunately just open in the UK, and we don't have the facilities to get this open in any other countries, unfortunately. So what about outcomes? We've talked about trials. We talk about progression-free and overall survival. These are things we like to use because they're sort of objective hard endpoints. Certainly overall survival is, and progression-free has a fairly solid endpoint based on imaging. And we know they're useful. They're useful for separating out our Simpson grades. They're useful separating out our integrated molecular diagnostic classes as well. And we traditionally, as surgeons, we're quite broad in what we report in terms of our outcomes, good outcomes, bad outcomes. But there's no consistency in what we report or how we report them. And it's really that morbidity risk for patients that should be driving up the goals of the standards of our surgery and the standards of our treatments to help improve quality of life for patients. So we've developed in Liverpool, this study is now finished. It's called the COSMIC study. This is looking at what core outcome sets we should have for meningiomas in clinical studies. The reason this is important, I'll give you an example here. So imagine we're doing the seizure prophylaxis trial, and we set up 2 clinical trials. One, we decide to measure the number of seizures per month, and the other one, we decide to measure time to first seizure. Now imagine both those trials are positive, and that both drug A and drug B seem to reduce seizures. What we don't know is whether drug A or drug B is better because we've measured different primary outcomes. So by having a core outcome set, it allows us to run trials and across multiple different territories. And if everyone's using the same outcomes, then it means that you can compare different trials and pool data together, which is more useful in terms of working out new treatments. Of course, outcomes are things that people report. Could be the clinician, could be the patient, could be a performance outcome such as an objective neuropsychology test. And when you're thinking about outcomes, you need to decide what you're going to measure, how you're going to measure it, and when in the patient's pathway you're going to measure it. And those outcomes tend to be chosen or decided by the healthcare professionals as well as the patients. So what we did for COSMIC is we looked at both observational studies, so what are the outcomes for incidental meningiomas, and then interventional studies, those that have undergone treatment. And this is a fairly standard way of defining these core outcome sets by using the Delphi process, which is a series of questionnaires followed by a consensus meeting to come to a final list. And here's what we found. It's interesting that in the observation cohort, the incidental meningiomas, as well as the things that we would expect, like overall survival, progression-free survival, the patients were very, very focused on those social role functioning or emotional impact. And some of that may be down to the idea of having an incidental finding in your brain, in your cranium, for which you're not having any active treatment, but knowing there's something in there that might be growing. So that's what came out of the observation cohort. But in the intervention cohort, interestingly, those factors were less important, and patients and healthcare professionals were more focused on extent of resection, physical function, and neurological status. So these are now finalized, and they're being written up for public presentation and publication in due course. We did this project with buy-in from lots of organizations. I've just noticed to my embarrassment that the EANS was not involved in this project, so apologies, please accept them. But it's a very useful piece of work. So what's going on in future? So we've already seen that really nice data from Dr. Sam about the integrated predictive modeling. We've seen this really nice paper that's published recently about what systemic treatment options may be available. We know more about the pathways involved in meningioma growth. So as well as those precision targets for the drivers, people are also looking at the immune environment and whether immunotherapy is useful. So I think the future really is what we might call meningiomics, which is integrating all of that data, patient factors, imaging, methylation class, biological information, to really work out what the risk is, identify targets for future trials. And this is what you really need. What we really need to be doing as a global community for meningioma patients is to integrate it all together to get the right patient on the right drug with the right target, and hopefully we'll have the right outcome, which is a response to treatment. So thank you for listening, and happy to take any questions.
Professor Jenkinson, thank you very much for this very nice, inspiring talk, and very much looking into the future, I would say, into the future of meningioma management. There's already one question from the chat. Dr. Matlak asks, in what cases of incidental meningiomas surgery would be the best option in your opinion?
Oh, I think if you ask 10 different neurosurgeons that question, you probably get about 20 different answers. I mean, I look at the patient, the age, the comorbidities, the meningioma location, and even considering all those things, by and large, I come down on starting at least with an initial period of active monitoring and interval surveillance. I think a lot of people could probably avoid the need for neurosurgery, because even if we do what we consider a perfect neurosurgical procedure, just the virtue of having your head open makes you a different person. It will somehow affect some subtle cognitive issues, I suspect. We're giving them a head injury after all, and they've got to recover from that. So I tend to monitor actively. Some people would argue that some of the more skull-base located lesions should consider for more upfront treatment, possibly with radiotherapy techniques rather than necessarily with surgery. But I'd be interested to hear my surgical colleagues' thoughts on this question.
I think also the COSMIC project you just mentioned showed that there is no real consensus, and that, yeah, there are different opinions on that topic. Yeah. So maybe a question from my side. Can you imagine, maybe not in the near, but in the far future, that it's necessary to have molecular information in the OR in order to balance the extent of resection? Do you think there might be a scenario sometime? Because we have effective drugs, or? Yeah,
I mean, that would be projecting far into the future, would require, Felix's Nanopore technology to be in the theater by the sounds of it. But, people are looking that way. And I know people, for example, are in the glioma world looking at whether you can get an intraoperative diagnosis of IDH wild type or mutant that might determine how aggressive or not aggressive you are in terms of prognosis. So I suspect it will come in the future, but certainly not, I wouldn't say not within the next decade, I don't think.
Okay, thanks. Any more questions from the audience or the panelists, maybe?
Not a question, but a comment on your...
I would actually like to ask Michael, or answer to Michael's call for commenting on the management of incidental meningiomas. My concern is, I wonder how you deal with this. What about compliance? I mean, it usually works to have the patient come back to you with a scan for a couple of years, but what happens afterwards? How do you make sure that they don't vanish? Whenever, when I recall real disasters, real meningioma disasters, people dropping out of, surveillance imaging strategies, this plays a major role. How do you deal with this problem?
Because we have the integrated National Health Service in the UK, it's much easier to keep a track on patients and keep them in the system. So it's a concern always, but we try and put the emphasis on the decision being shared, so the patient has to take some responsibility for their healthcare. It's not all down to the doctor.
Justine, we can't hear you.
Sorry. I think there's one more question from Professor Pruneau, right?
It was not a question, it was just a comment about the extent of resection. We have to be careful with adjunctive techniques that could motivate you to go further that you would like to do, because when you have the feeling that you need to stop, if you have another argument who invite you to go further, you will start to be at risk, or the patient will be at risk on that moment. So just one comment about how we have to carefully integrate the intraoperative techniques in relation with the extent of resection, especially for skull-based meningiomas, maybe a little less for convexity meningiomas, but for skull-based, at least we have to be very careful.
Yeah, I couldn't agree more. You know, the worst decisions we probably make as surgeons is when we push our resections and when we should have stopped earlier, I suspect.
And another comment regarding incidental meningioma. The first thing that I will do is to ask the patient if the patient has any hormonal therapy. And the first thing that the patient has to do is to stop any hormonal treatment. And you could be surprised how the tumor can decrease in size after the interruption of such treatment.
Yeah, that's also an important comment, I would say. There's one more question from the audience. I know that Dr. Jenkinson has to leave for another important meeting, but there's one last question. Do you examine factor 13 post-operatively on a regular basis? Maybe it's not only to Dr. Jenkinson, but to all the surgeons in this panel.
I don't know. I don't know if anybody else does.
No.
Any opinion on that?
I don't really have an opinion on it. No, sorry.
It's not done on a regular basis, I would say.
No.
Okay. So, Dr. Jenkinson, maybe thank you very much for your input, for your nice talk. And I think you have to leave. Thanks again.
Thank you very much.
Thank you. Are there any more questions to the other speakers?
If you have just 2 seconds for me, if you accept that I share my screen, I would like to make an announcement if it works. Yes, now I can share my screen easily. So just if you are interested to meet many very impressive surgeons, I invite you to join us in Brussels for a Meet the Masters symposium on all the topics that our discipline in neurosurgery, and this is the list of faculties. You see how impressive it is, and the concept of this symposium is to have direct contact with the master to treat about all the possible topics, but with direct face-to-face discussions. And it will be organized on a very historic site, which is the Bethel site of Waterloo, and you remember the history that happened there in the 19th century. So it will be my pleasure to welcome you there. You see the website that is under construction, but you will be welcome if you would like to join us in Brussels at the beginning of September. It's 7, 8, and 9 September. Thank you.
Thank you very much for this teaser, for this advertisement. And I think a lot of people are interested in this, in this offer. Any more questions from the panelists, maybe to our other speakers, to Felix, Matthias, Professor Bruno? No more questions? Okay. Yeah, then I would like to close this session, this webinar. Thank you very much to all of you for your interest in our webinar, and also for your active participation in the discussion. And yeah, on behalf of our section, I would like to say take care and see you next time on our next webinar. All the best.